Upstate Medical University in Syracuse, New York invites you to be the informed patient with the podcast that features experts from Central New York's only academic medical center. I'm your host, Amber Smith. Do you know your heart attack risk? Today, I'm talking with a cardiologist about the importance of knowing your risk and tests that can help. Dr. Adeeb Al-Quthami is an assistant professor of medicine at Upstate and the director of cardiovascular imaging. Welcome to the Informed Patient, Dr. Al-Quthami.
Thank you for having me.
The test we're talking about first is the coronary artery calcium test. What can you tell us about it?
The coronary calcium test is a fast, painless CT scan of the heart that looks for calcium buildup in the coronary arteries. The arteries that supply blood to your heart. Calcium means plaque has been forming, which is an early sign of coronary artery disease. The scan takes only about 10 minutes, and there are no injections or no dye.
So it's not an x-ray, but it's an image. The patient won't feel anything. It's a picture that's taken of their heart area.
Exactly. Basically, the way to think about it is it's an advanced form of an X-ray. So it's an X-ray that will assess your heart attack risk.
Are there any symptoms that would lead someone to think maybe I'd like to get a calcium score test done?
So a calcium score test or a coronary calcium score is really designed for asymptomatic individuals, individuals who don't have symptoms but want to assess their risks. It's ideally for patients between the ages of 40 to 75 with uncertain or intermediate risk. Maybe they have borderline cholesterol or elevated blood pressure or a strong family history of heart attacks. This test gives more information about their overall risk for future events or future heart events and allows the clinicians, the providers, to tailor medications and therapy to address that risk.
So if you see that someone has calcium buildup in their coronary arteries, how does that help determine their heart attack risk?
The coronary calcium score gives you a score. So a 0 score is great. It means that the individual has a very low near-term risk for future heart events. Any score above 0 means the plaque is present in the coronary arteries, and the higher the score, the more the risk. Once the score gets into the hundreds or sometimes into the thousands, we consider that clearly elevated or very elevated risk and often treat the individual aggressively.
The test is not new, though. Are more cardiologists using it today than 20 years ago?
Correct. The test is not new. And the reason why we use it now is that it became more widespread due to improvements in technology. Radiation is now very, very low, which is roughly equivalent to what you get from natural sources in about a year. And in the last several years, it's been included in the major guidelines as a great tool to refine risk.
So why does Medicare and other health insurers usually not pay for it?
Most insurers want large school proof that scanning everyone reduces heart attacks. It's often not covered because it's considered a screening test. As a result, most people who do get this test pay out of their pocket.
But if it screens for coronary artery disease, it is a screening test, right? And wouldn't it be useful for everyone at a certain age to have it done?
The data is not there yet. What the insurers want to see large population-based data or evidence that on a population level, for example, for the entire United States, that if we screen everyone, that we can reduce risk for everyone. So that's before the insurers would actually, I predict, will cover it. But in general, and on an individual level, it does screen for risk, and it's one of our powerful tools to personalize persons at risk.
You said one of the tools. So that tells me that the calcium score for one individual, another person could have the same score, but totally different treatment recommendations based on other things they have going on, right?
Exactly. Coronary calcium score is only one tool in looking at an individual or a patient. So we also look at, person's age, blood pressure, cholesterol, diabetes, smoking, weight, and family history. The calcium score just adds another powerful layer of information that allows us to personalize care.
This is Upstate's The Informed Patient podcast. I'm your host, Amber Smith. I'm talking about coronary tests with Dr. Adeeb Al-Quthami, Upstate's Director of Cardiovascular Imaging. Now let's talk about the next phase of cardiac risk assessment. What is quantitative coronary plaque analysis?
Thank you for asking that. Quantitative coronary analysis, often called QCA, is one of our advanced ways of measuring plaque and artery narrowing with much greater precision than just looking at pictures. The traditional way of looking at narrowing of blood vessels is we look at a picture of the vessel and we say, oh, that artery looks narrowed. With quantitative coronary artery analysis, or QCA, it gives us exact numbers, how much plaque is present, what type of plaque is there, how thick it is, and how much of the artery is blocked or narrowed, and how it changes over time. It's extremely helpful because it turns imaging into real, measurable data so we can track progression, monitor response to treatment, and make much more confident decisions about whether someone needs medication, further testing, or a procedure.
Does a patient have to have a calcium score test first before the QCA?
No, typically a coronary calcium score is included as part of the QCA. So an individual does not need a separate coronary calcium scan to get a quantitative coronary analysis because it's often actually included as part of quantitative coronary analysis.
And insurance companies and Medicare will pay for the quantitative coronary plaque analysis?
Yes, so insurers, given the right indications or the right reasons, will cover coronary angiography and quantitative coronary analysis.
So, what are the symptoms that a patient might have that would qualify them for the QCA?
So again, it's symptoms and risk. So it's usually designed for patients with intermediate or unclear risk and have symptoms suggestive of coronary artery disease. So these symptoms can be chest pain, shortness of breath, anything really with exertion. So when they try to exert themselves, they develop symptoms, and these symptoms would go away with rest. If someone is very low risk, insurers sometimes would not cover this test. They would ask for more basic tests like a stress test. But if someone's very high risk, or we think that they might have coronary disease at much higher predictive risk, then they would not cover. So it's really designed for the patients who are in the intermediate unknown risk and they have symptoms. Most insurers would cover this test.
Now, how is the test done?
The test is done for a general CT, like any other CT scan. So you lie on a CT table, you have a few stickers go on your chest, you hold your breath for a few seconds, and that's it. For a coronary calcium scan, there's no injection, there's no dye. For coronary artery angiography or quantitative coronary analysis, there is an injection, there is a dye analysis. We give dye during the procedure. Both tests are fairly quick. For a coronary calcium scan, it's about 5 to 10 minutes. And for a coronary CTA or coronary angiography with quantitative analysis, it also takes about 5 to 10 minutes.
Does the QCA replace the need for other imaging, echocardiography, or stress tests? Or might you recommend a patient, after you look at the analysis, that you need to get more information with some additional testing?
Quantitative coronary analysis and coronary angiography is a tool among many tools we use as cardiologists to assess risk. Other than family history, personal history, and risk factors, we look at an ECG, an echocardiogram, sometimes a stress test. So we look at an individual globally in terms of the different tools we have. And the more information we have and the more data we have, the more we can provide personalized care for the individual.
Can you talk about what some of that personalized care might be? What are some of the treatment recommendations that might come after a plaque analysis?
Most importantly is diet and lifestyle. There are factors that we can change and there are factors that we cannot change. The factors that we can change, diet, improving someone's diet or lifestyle, exercising more frequently, and then addressing factors that increase the risk for future development of plaque. Like if someone were to have hypertension, we treat their high blood pressure. If someone were to have diabetes, we treat their diabetes. And we look at cholesterol. If someone has high levels of the bad or LDL cholesterol, we treat their LDL or bad cholesterol more aggressively. And then there's factors that we can change, like age or genetics. But the factors that we do have control over, such as risk factors and medications that we can give to address these risk factors, we often treat more aggressively and closely.
Do you ever come across a patient that has an emergency need? They need surgery right away or catheterization?
All the time. As a cardiologist, one of our core basic roles in the hospital and in the outpatient setting is risk assessment of patients' coronary or heart risk around the time of the surgery. So frequently, as an individual ages or has multiple comorbidities or risk factors, they increase the potential risk of heart problems around surgery. Often the surgeons or proceduralists would refer these patients to us to assess that risk. And coronary CTA or coronary angiography and plaque analysis is one of many tools that we use to address those risks and provide further personalized care in terms of if the patient or the individual is safe to proceed with surgery.
Well, I imagine you will tell me that having a healthy lifestyle, eating right, exercising is important lifelong. But at what age would you recommend people really start thinking about their cardiac risk?
As we age, the risk for cardiac issues or potential cardiac problems statistically increases. So I'd say around the age of 35 to 40, it'd be advisable to someone to think about their heart risk, especially if they have risk factors, smoking, diabetes, hypertension, or a family history. After the age of 40, the risk starts becoming much more, especially with risk factors or family history. My recommendation would be to talk to your doctor about your long-term heart health, and coronary calcium screening or coronary angiography might be part of that conversation.
So, family history matters. If you have parents or grandparents that have issues with their heart, you probably need to be aware of that earlier rather than later.
Absolutely. Not only parents and grandparents, but also siblings. A lot of our patients have older siblings who had heart attacks, or sometimes even younger siblings who had heart attacks. So that's also an important part of the family history.
This is very good information, and I want to thank you for taking time to share it with us, Dr. Al-Quthami.
My pleasure. Thank you for having me.
My guest has been Dr. Adeeb Al-Quthami, the Director of Cardiovascular Imaging at Upstate. The Informed Patient is a podcast covering health, science, and medicine, brought to you by Upstate Medical University in Syracuse, New York, and produced by Jim Howe, with sound engineering by Bill Brokel and graphic design by Dan Cameron. Find our archive of previous episodes at upstate.edu/informed. If you enjoyed this episode, please invite a friend to listen. You can also rate and review the Informed Patient podcast on Spotify, Apple Podcasts, YouTube, or wherever you tune in. This is your host, Amber Smith, thanking you for listening.